Okay, let's go ahead and start. I'll start with the introduction. So welcome to the Indiana Rural Opioid Consortium webinar series. Today's topic for our webinar is prescription opioid awareness. What do patients know and how can healthcare providers increase their patients' opioid knowledge? We have with us our presenters, Lauren Chars, who received her Doctor of Pharmacy degree in May 2020 from Butler University. She currently works at CVS Health in Milwaukee, Wisconsin. Throughout her time at Butler University, she enjoyed learning more about underserved health populations through helping to establish a student chapter for the Indiana Rural Health Association and volunteering at Butler University Community Outreach Pharmacy. And also joining her is Trish Devine, who is an associate professor and director of interprofessional education in the College of Pharmacy and Health Sciences at Butler University. She received her Doctor of Pharmacy degree from Shenandoah University and her Bachelor's of Science Pharmacy degree from Butler University. And I will hand the screen over to Trish and Lauren. Just a few housekeeping items. If there are any questions, use the Q&A section. And there are some questions where we will ask you to participate in a poll as well. Trish and Lauren, the floor is yours.
Thank you. Thank you so much for having us. And we hope to be able to share what we learned about opioid awareness from patients who receive prescriptions from an independent pharmacy. So our objectives for the webinar are listed here, but we hopefully, by the time you finish listening to our webinar, that you'll be able to identify 2 top resources patients reported on how they were made aware of their medication wasn't opioid, be able to list 2 components patients should be educated on regarding their opioid medication, and then also identify 1 area in your practice that you can change to increase patients' opioid awareness. So I'm going to skip this because you're listening to it recorded, so we don't need to know your background, but if you were live, we would have loved to know. But just giving a background on why we did this study. So we did a pilot study on opioid awareness, evaluating what patients knew about their opioid prescriptions. And what interested us on doing this was that there are very many statistics on opioid misuse. 92 million people are using opioids prescriptions, 11.5 million are misusing them, and there's been reported 47,000 opioid-related overdose deaths. Also, another research study just in the last year asked millennials and our baby boomers about obtaining opioids, and 52% of our millennials and 41% felt like it was really easy to obtain opioids to misuse them. We also wanted to look specifically here in Indiana and rural communities, and the difference between rural and metro is 69% of people in our rural communities know someone who misused opioid prescriptions versus 40% in our metro communities. Deaths to opioid pain relievers here in Indiana, in 2018, there were 930. In 2019, there was 1,135. And then we saw a little dip in 2020, but remember that COVID was happening. So potentially there were 783 reported. That could have been underreported due to the focus being on COVID. Also in Indiana, there have been 65.8 opioid prescriptions are written per 100 persons. Comparing that to the United States, it's 51.4 opioid prescriptions are written per 100 persons. So you can see we still have issues here in Indiana that need to be addressed to help decrease some of these opioid misuse and opioid overdoses. So a little bit of background of the main reason for people misusing their prescription pain relievers. This was done from one of the studies from SAMHSA, and they looked at why people were misusing their opioid prescriptions. So SAMHSA is our Substance Abuse and Mental Health Services. They do research on this annually in different areas. In the year they focused on prescription misuse, they found that 62% of people were misusing prescription pain relievers because of their own physical pain. So either A, they were not following their scheduled prescription instructions for their own pain medication, or they were using someone else's, but they were doing it because they had pain and they weren't receiving the relief they needed from their own medication. So I think that's one area of education of letting patients know the expectations of pain relievers. Are they truly going to relieve pain 100% of the time? And usually they are not. They decrease the pain, but to get complete relief might be unrealistic depending on whatever the issue is that's causing the pain. So just educating patients on expectations of the opioid prescription and the amount of relief they should have from it might help patients realize the awareness of their prescription and not try to seek complete pain relief. The other areas that reasons why patients were wanting to misuse or were misusing pain relievers was to feel good or get high, and then followed by they wanted to relax or relieve tension. So we wanted to ask you to stop and think about what was the most common source where people who misused opioids obtained them. So do you think it was from a prescription from a prescriber? Was it bought from a friend or a relative? Was it given by a friend or a relative for free? Or was it bought from a drug dealer? So here's our poll, and just giving you a time, those that are listening to it recorded, just to think about your answer, and then we'll move on with what the research has shown.
We also have some participants, some attendees on the call, so we could go back to the first poll question if you want to get more about their background.
So thanks for answering. So the most common source, we'll continue to move on. So the most common source where people obtained their pain relievers were from a friend or a relative. So 53% received them from a friend or relative. If you broke that down to a little bit more, 40% received it for free from their friend or relative. About 9% bought it from a friend or relative, and about 4% actually took it, basically stole it. If they didn't receive it from a friend or relative, it was from a prescription legitimately from a doctor, but they were misusing it. So they were not taking it as scheduled, so they probably were not receiving that pain relief, and so they took more than they were prescribed. So knowing where people were misusing it, why they are misusing it, I think will help healthcare providers learn how to make opioid use safer. We looked at a couple studies to try to understand what things are value of patients, how they're educated on their opioids. And so there was a study with palliative care patients, and basically they were given, one group was given educational materials on how to store their opioids, how to use them, how to dispose of them properly. The second group did not. And those who did receive the educational materials were more likely to keep their medications protected and more aware of proper disposal. Another study, or a couple of other studies we looked at, were auxiliary labels. Would it be helpful for patients for an auxiliary label, which is an additional label on a prescription bottle when somebody obtains their prescription medication that states additional information about that medication? And would it be helpful to have an auxiliary label saying it's an opioid to help them become aware that their prescription is an opioid? But we looked at studies on auxiliary labels to see their usefulness. And one study had 4 different groups, one group with the auxiliary label and counseling on their medications, one just an auxiliary label. The other group just received counseling, and the 4th group received neither. And the study showed that individuals that received auxiliary labels were able to correctly and completely recall the information on the label compared to the groups that did not receive an auxiliary label on their medications. The other study studied patients that were given auxiliary labels on their medications, and the others did not. And 13.2% more of the patients were able to recall questions about their medications compared to patients who did not receive an auxiliary label. So just showing that auxiliary labels can be useful.
All right, this kind of comes up to my section, but did we first want to pause and just kind of ask Heather and Ashley about their background, either through the poll question or the chat function? So just wanted to kind of tailor this discussion to our participants and ask about your career or background. Okay, so it looks like I have other on the poll, and then it looks like Heather also said public health in the chat. So, okay. Okay, Ashley says marketing specialist, great. So those are some different roles. I know that we didn't know whether we would have some actual prescribers on the call or various other healthcare roles. And so now we can kind of understand who's on the call here. This may not apply directly to you. The next couple slides I'll share, but something to keep in mind of when you're kind of providing guidance to physicians and other prescribers, and just from a public health perspective, how you can implement changes or legislation or guidelines in your fields. So I'm Lauren Chars again, and I'll be talking a little bit more about the guidelines and legislation available to us and things that have come out, and also things that we can consider for future guidelines and legislation. And then I'll also be going more in depth into our specific study we conducted and how we set up that study, and also how we gained those results and what we interpreted from those. So first of all, we have prescribing guidelines surrounding opioid prescribing, and these are some that are clinically based options that the CDC has put out for people to follow as guidelines in their practices. And then we also have legislation. So there's a couple different things. Some that are actual law and some are just kind of more guidance, but they are great things to keep in mind. So often when we have prescribing guidelines, initiating and continuing are big options, because someone may have some acute pain and had a short course, but then when does this issue kind of become a chronic pain issue, or when do we decide to continue these opioids term, how that works? And there's some guidance along dosage, duration, follow-up, and discontinuation to make sure we're using those safely and appropriately. And one specific recommendation could be, for example, in the dosage, to try using some of the immediate release opioids before moving right to a more higher, heavier duty, extended release opioid that could cause the patient additional harm and could have increased or just higher effects than the patient really needs to control their pain. Another big topic is duration. It's suggested to start with a very short duration if it's a patient's first experience with an opioid before progressing to something longer. For example, maybe a 7-day duration versus automatically giving the patient 30 days worth of opioids that they may not even finish and may have relieved their pain by then. And then that just creates a greater opportunity for the patient to continue taking the medication on accident or just because it's available to them, and develop a dependency for that. And also just continuing to have frequent follow-up with prescribers and make sure that physicians and nurse practitioners, other prescribers are monitoring and following up with the patients, and then discontinuing when appropriate. So we don't have patients on these opioids long-term when they technically are either not receiving benefit from their initial opioid and need to be adjusted to a new therapy, or because they want to also think about alternative ways of managing pain if their current opioid regimen is not appropriate for them, either due to it's not efficacious and it doesn't work well, or because it's providing them with some harm as well. And then again, to that point, we want to make sure we're really assessing the risk and harm, especially if patients are on higher doses. Even if they're using their medications appropriately, they could be at a higher risk of an overdose or adverse events from opioids. So making sure that we consider the benefits of possibly having naloxone on hand as a rescue medication if a patient was in an emergency situation that would require that. So here's some kind of baseline guidelines to thinking about how opioid prescribing occurs. And then moving on to more of some legislation piece, we wanted to kind of highlight some things about Indiana specifically as well, since we are the Indiana Rural Health Association. Indiana has recently passed a bill that says that all opioid prescriptions should be electronic to kind of reduce some forgery and just kind of limit some of the paper copies that are questionable, and also just ease the requirements prescribers have to make, because it's a lot of times surprisingly easier to do the electronic version than have the prescriber remember to write a lot of different components, and then the chances of forgetting. So that makes it a smoother experience for patients as well to just have an electronic prescription sent to the pharmacy. However, though, there are a lot of things we need to consider where many prescribers' offices may not be equipped for this technology. So currently there's also a lot of exceptions and waivers to this requirement if prescribers are not able to provide that electronic prescription. There's also a current bill that is in the legislature in Indiana too, trying to prevent this. So overall, it's really not the mandatory requirement just yet, but definitely something that people are looking at to cut down on forgery and kind of streamline the process to make sure that prescription pads and other things are not getting into the right or the wrong hands, excuse me. Another requirement that you see in the middle of the slide is that a 7-day supply for first-time opioid users has been kind of a guideline, and a lot of, it's not only legal, but a lot of insurance companies, I've also noticed in my practice as a community pharmacist, have required when we receive an insurance rejection while running a claim as well. So they really try to limit people who have acute pain and are not used to taking opioids to a very short-term supply to prevent any kind of additional harm to them. And as we also mentioned already, there's use of auxiliary labels. In this yellow box here is kind of an example of what that might look like on the bottle that the patient's receiving, where they might have a sticker. And then only 5 states require that at this time. So just kind of driving the conversation and encouraging people, individual state legislatures to consider the benefits of doing this and implementing this for the laws surrounding the opioid prescribing. So that leads into a little bit about our specific study we conducted. In the gray box above, it contains the title of the study. So our full title was Evaluating Patients' Knowledge Regarding Opioid Prescriptions in an Independent Community Pharmacy. And we consider this to be a pilot study because it was the first of its kind. And to our knowledge, we don't really have any other indication that a study to our same format was performed elsewhere. And it was a really unique setting for us, especially I wanted to kind of highlight being a rural health association, and some of our smaller communities really rely on the independent pharmacies to supply medications to their smaller communities. And so we really enjoyed doing this and hope that the results and the information we have to share with that can translate over to some of the environments that you work in. Our overall objective for the, oops, can you go back one more time? Sorry. Just wanted to highlight in the blue box here, the overall objective of the study was just to evaluate patients' knowledge regarding their opioid prescriptions and also identify what resources that were used to educate those patients. So the way that we performed this study, it was targeted to patients 18 and up. So we focused on the adult population at a specific single independent pharmacy, and they received an opioid medication. And with that medication, they were provided an auxiliary label that kind of indicated that that was an opioid. And then they also had an educational brochure supply more information with opioids to consider and how to take the medication, and also for considerations and to make sure that the medication gets into this place and not in the wrong hands. Once they received the prescription, we contacted them about 1 week after through a phone and discuss and go over a survey. And so this kind of examined some of their prior knowledge regarding opioids, also asked them a little bit about how they were educated about their prescription. And is it freezing? Okay, great. So here's an example of the so it can explain how to take the medication, and also things to ask the pharmacist about. And so as go through the points, it also talks a little bit more about that storage and disposal component, making sure that the patients know how to safely dispose of opioids and keep them out of reach of other people. And the overall survey consisted of 9 questions. It asked a little bit about their demographic information, and then it also covered, again, their knowledge of opioids. Many patients in this study had quite an extensive prior knowledge of opioids as well, because they had been on these medications for a very long time. And it also broke down the different parts of education, whether it was from prescribers or whether it was from some of the other supplemental brochures and stickers and labels that we provided. So I just wanted to share some graphs that represent the results. So the first kind of main question, and one of those that drove us to do this study, is, are you aware that a medication of yours is an opioid? And because we kind of expected that there may be some patients, whether it's health literacy issues or just varying reasons, that they may not actually know that their pain medication is an opioid, especially patients on very complex medication regimens where they don't always know what they're taking. With this results, we were kind of surprised, but also we were pleasantly surprised, because we were definitely glad that the patients realized that the medications were an opioid. But overall, 94.4% definitely knew that the medication they had was indeed an opioid. Often we attribute this to a lot of, again, our chronic pain patients that have been taking these medications for a long time. Another main question we asked about is just, how were you made aware that that medication was an opioid? Because again, there's varying sources. There may be healthcare providers, and there may be some other reasons, societal and other lifestyle reasons. So ultimately, their prescriber that prescribed them that specific medication was the overwhelming answer. But we also had pharmacists come in second at 27.8%. And then some other reasons were the opioid sticker, which showed that some of those stickers were an answer to that survey response, and then a family member or friend. And then there are also some other reasons, such as self-education online. Some patients chose to respond in the other category, that just overall they had been taking it for so many years in their life experience that that's how they knew. So we kind of documented things that way in the other category as well. And breaking it down more specifically, the last question was about awareness. This is a little bit more specific to the formal education piece and the prescription counseling piece. Who or what educated you on your opioid medication? Again, overwhelmingly, the physician was a big response. And to note as well, many of the patients that we discussed, they had a chronic pain specialist as well that managed their pain. So that was interesting to note. And then again, we had some other responses of pharmacists, some self-education, which obviously sometimes can be problematic if they're not getting the information from the right sources. And then unfortunately, some also responded that they received no education, which we were a little bit disappointed about, and obviously wanted to strive to improve that area so all patients get their education that they need. And then this is a great representation of what were the different components that patients were educated on regarding these medications. A big focus in this presentation is just to kind of identify what areas the patients need to be educated on, so you can take these and implement these in your practices and in your careers. So we have each of these different categories. So we have what an opioid is in general, and kind of breaking down the chemical reasons why opioids may be addictive and what they're made out of. How and when to take the medication, so patients are following those directions and taking that safely. Alternative non-opioid medications for pain, so things like ibuprofen or Tylenol or other pain relievers that are not in the opioid class. And there's also alternative non-medication treatments for pain, things like physical therapy, acupuncture, or other ways that are not actually medications that can help relieve the pain. And then storage and disposal, making sure that patients are aware of those things, possibly recommending some lock boxes or ways that you can stow the medication away from others, and how to dispose of that. One thing that I've also recognized in my community pharmacy recently is there's been some packets called Dispose RX, and they come in little powder packets. And so you're able to mix those with water, and it helps dissolve the medication. So those are really cool options to give patients, especially if they're going to be on a short-term supply and may not even take all of the medication. That way they can get rid of it before it becomes someone else's problem and contributes to our further issue of addiction. And also another point would be the side effects of the medication as well, because as we know, they can contribute to problematic side effects the higher dosage you go, and just in general, many patients also that aren't tolerant can experience side effects even at low doses. And then at the end, we do have an other category, and then none of the above, or I was not educated on this medication, which does make us a little sad because we want to make sure that everyone gets adequate education. So these are some areas that you can focus on when you are improving opioid education. And this question specifically narrows in on who or what answered your questions regarding the medication. Prescribers ultimately were the highest option choice again, but then pharmacists came in just below them at 38.9%, which was great to see, because the answering questions component is a really important role for pharmacists being very accessible healthcare providers. So another prescriber might do the initial counseling and education, but pharmacists are often right there able to answer questions when patients are not able to get in or able to directly ask their prescriber about something. So that was great to see that patients recognize the pharmacist role as well. And there is a category of some patients had other for varying reasons, again, mainly the same one that we had talked about in the previous questions. And then some did say, I didn't have any medication questions. Conclusion for the study. And our patient specifically, most patients were aware their medication was an opioid. It would be great to see if we could expand this to other areas and environments and see if this really make a big impact in patients who really have a lot of knowledge that the medication was an opioid. But for our purposes, most really truly did know that this was an opioid medication. And then also, while some of the auxiliary labels provide some benefit, the prescribers and pharmacists and other healthcare providers play the larger role in providing education. The majority of patients really valued the relationship with their healthcare provider to provide that education and counseling.
So we wanted to compare our study to the couple studies that I had mentioned earlier in this presentation. So one of the similarities was that our study showed that auxiliary labels provided a benefit, and that was similar to the study I had mentioned earlier. And one of the differences is that the study I had mentioned earlier found benefit in the educational materials, where our study did not show that none of our participants actually selected that the brochure that we provided them with any information. But once, as you notice, our study was small, so we're hoping that potentially has something to do with it, as well as it appeared many of the participants had been on these medications a long time, and so maybe they felt like they knew what they needed to know about their opioids and did not refer back to that brochure. So how can this study help with different practice implications? I think our study definitely showed the emphasis and need for healthcare providers to counsel patients about their opioid medications, as that they were the #1 resource of receiving education. And so it's very pertinent that our healthcare providers know what to educate their patients on and to continuously to provide that information. Another is to emphasize opioid education and counseling in healthcare provider curriculums, as they're our future in educating our patients. So make sure that we are educating our future providers correctly. And education should be provided to students that I just mentioned, but also our patients, healthcare professionals, healthcare providers, anyone that has any access to opioid patients on how to take it, how to keep their medication safe. Because as you recall back to the early on the graph I showed you, that most people who misuse prescription opioids are obtaining it from friends and family. So we want to make sure that people who have opioid prescriptions, to make sure they are locked up, kept safely, and disposed of correctly when they are no longer needed. So talking about safe medication storage and disposal, 2/3 of teens who misuse pain relievers said they got them from family and friends, very similar to the SAMHSA study with all the adults. And just to encourage legislation and regulation of opioid labeling and education. So one thing I'd like to mention is our study early on in February of 2019, our data was actually used for the Indiana Senate Health Committee to use our numbers to help implement the bill that was passed to require auxiliary labels be placed on all opioid prescriptions to make patients aware that their prescription is an opioid. So the numbers are still low of states requiring that, and I do feel that that is helpful to make sure patients are aware that the prescription they're taking is an opioid, and to keep it safe and to dispose of it correctly once they are done with that need of taking it. The limitations of our study was there was a lack of differentiation between the first time filling an opioid versus a refill. So it would have been nice to know, had we asked that, if these patients who were not educated on or did not use the brochure, was it because they have been on these medications for a long time, so it was a refill, versus somebody who is just receiving an opioid. So having that differentiation would have been nice to have done. It was a very small sample size. It was conducted in one independent study. So our results cannot be generalized just because of these limitations. So that leads us to our future research. So it'd be great to be able to do this in different pharmacies. So have an urban versus rural versus our commute, like our CVS, Walgreens, Walmarts. So our big organizations and independent pharmacies. So getting a larger sample size so it could be generalized, differentiating between acute and chronic refills, having just seeing what is taught in these healthcare provider curriculums about opioids. You know, are we teaching our future providers on how to educate patients on how to taper their opioids, and what their expectations are of when you do take an opioid? Should they expect to be relieved of pain 100%? And if not, what are some alternative treatment plans that could help them receive that 100% relief from pain? Also, the impact of COVID-19 on the opioid misuse and overdoses. It has been reported that over 40 states have seen an increase in opioid-related deaths. And you know, as you can, if you remember back on our earlier slide, we had in a year's time about 45,000 drug overdose deaths, and it has been reported that we have seen a huge increase. So those are definitely future things for us to look at. And then our last Zoom poll for today is, what is one area in your practice that you can change to increase patients' opioid awareness? So I think all of these are great ideas, ways that we can improve our practice and help keep our populations safe, and to continue to educate our patients, family, and friends that potentially have opioids or can be exposed to opioids. Always continually trying to increase legislation to continue to have policies on opioid safety. And I think all of these will really help improve our population health. Hopefully we will see a decrease in opioid misuse and opioid overdoses. With that, concludes our webinar, and we have time for questions. If you are watching this after recorded, you are welcome to email us at any time, Lauren or myself, any questions that you might have.
Thank you, Trish and Lauren. If you have any questions, you can use the Q&A option at the bottom to ask your questions. I just had one question, Trish, regarding like where the most of the people get their opioids from, and it is usually from family and the relatives. Is there any specific education or information that is directed towards the elderly population, as those are the ones who are usually getting a lot of the opioid prescriptions, and those are the ones who usually hoard their medications in their cabinets, which then gets visited by their grandkids and other members in the family. So is there anything specifically directed towards that population that we can do in addition to everything that you mentioned?
Yes, that's a great question. So a lot of our elderly do live at home. Like 90% of our elderly are living at home, which is a great thing. However, they do, unfortunately, lose access to family and friends to their medications. So we usually try to incorporate our caregivers to educate them, as well as helping the elderly know that they should lock them up. Probably the worst place to keep them is in your bathrooms for two reasons. The storage, the humidity in there it can break down the medication, so it's not good for the medications themselves. But also, that is the one place that family and friends have access to your area without anybody else being around, because they lock themselves. You go to the bathroom, you lock the door. So not having them in there, having them more in an open, like in space that you would be in as well, that you could protect your medications from others looking to see what you have and potentially taking some is one way, and one thing we do to educate our elderly of keeping their medications safe. And Lauren had mentioned it, having a safe is nice, but it's not the easiest, because you always have to unlock it daily, and sometimes 3 or 4 times a day, to get your medications. And when you're not feeling well, so you are in pain and you're trying to remember the code to your family, you're locked safe, it can be cumbersome. But probably the next best thing is to keep them in an area that you know where they're at, so not openly visible, but in an area that you frequently are, so you can see if a visitor is looking at your medications or not.
Thank you, Trish. And we have a question in chat from Ashley. She says that, does evidence suggest that patient education improves patients' behavior in addition to their understanding about the medications that they're taking? And that also, what recommendations do you have around education resources for providers? And there's another part of that. Do you have recommendations on where to go for the most up-to-date information around opioids in our country? So there are 3 questions in one.
Yeah, so I'll probably answer them backwards, but actually IRHA has a resource page, and I might rely on Heidi or Amna to tell us, but I know we have that consortium that we actually have some resources. And if you email me, I also have a great resource like on how to educate providers on tapering their medications, because I think that's a big issue. We have seen that our patients have been put on opioids, but they weren't educated on how to taper and get off their opioids. So I do have information on that as well, on how to taper, but I know our IRHA has some resources on educational material. There have been some studies, yes, that educating patients does improve compliance of medications, as well as the disposal. We have seen an increase. So we have some take-back medication fairs, health fairs, and we have definitely seen an increase of those being used. So I do think these educational pieces are improving compliance as well as the disposal of opioids. And Lauren, I don't know if you have anything to add, and make sure I covered all the questions.
Sure. Well, to the first point too, I wanted to add too, when you talk about getting the caregivers involved in that first question, another thing, obviously the medication piece, but even the naloxone piece as well, because should there be any kind of emergency or situation, the patient themselves is not going to be administering that. So making sure that all people around the patient are aware and trained on how to use that as well. So that's something I've really tried to focus on, making sure if patients need that at the local pharmacy, that I make sure they are fully educated and answer any questions they may have before they leave, because that's another resource that can be really another safety thing for that patient when you talk about educating all the caregivers and people in the home. The other thing I wanted to highlight for resources actually is that the CDC has an iPhone app. It's purple. You probably can't see it very well right here, but it's called Opioid Guideline, and it has a lot of great resources, and also a calculator too that can even help you calculate this patient's total dose and compare it to morphine milligram equivalents, which kind of helps us assess their risk for needing naloxone and some of those other safeguards. So based on that, it gives a lot of information, and then it also kind of reviews more of the recommendations I had talked about on the prior slide for being conservative about starting lower and tapering off opioids. So it gives those current CDC recommendations that way. And then it provides some more of the actual guidelines and fact sheets. And then just pulling something up. Yeah, it pretty much has everything on there, at least from a healthcare provider perspective. I think when you need to go for more of the patient-friendly paperwork and guidelines, that is available online, but this app specifically has clinical tools for providers to use.
Thank you so much, Lauren and Trish, for the answer. CDC app is a great resource for providers. I agree. And I have included the link to the Indiana Rural Opioid Consortium resources that we have on our webpage in the chat. If we don't have any more questions, I would just like to say thank you so much. The recording will be available on our YouTube page, and we will share the link with all the panelists and the attendees for this webinar. Thank you so much.
Thanks, everyone. Thanks for having us.